We had a couple last minute people pop in, so we should be good to go. So, today we are going to talk about, I'm going to turn my camera off so nobody gets distracted. But, excuse me, today we are talking about managing patients with multiple insurance plans. So, patients that have secondary, tertiary plans. And I'm going to preface this by saying I love patients that have multiple insurance plans. I was in Dallas just this past weekend doing a 2 day billing and business seminar weekend. If you were there, thank you so much for coming. But we talked about this there. I love patients that have multiple insurance plans because even if I'm in network with one or both or all three of their plans, there are times when I can collect up to my full office fee from the insurance payments. And I think a lot of offices are missing out on a lot of revenue opportunities by either not dealing with secondaries or by dealing with them incorrectly. So I really want everybody out there to understand exactly how it works, how we deal with them. So the first step of managing patients with multiple insurance plans is understanding the different types of plans that are out there. So, naturally, we know the commercial plans through an employer, or they could be purchased through directly through an agent. But we have those commercial plans, whether it's through the patient, the spouse, maybe a second job, whatever it may be. Then we have self-funded plans. And these are self-funded employer plans. This today is not a lesson on self-funded plans, but we have to be aware of those because they are exempt from all state laws. So we really have to be aware of that when we're dealing with coordination of benefits. But there's something else, and when we get towards the end, we're going to talk about what else makes self-funded plans special when we're dealing with patients with multiple insurance plans. So the next type are COBRA plans. Hopefully everybody knows what COBRA is, but basically COBRA is if you leave an employer, whether you quit or are terminated, depending on the size of the employer, you have the option to self-pay for your same health insurance, dental insurance through them and maintain that coverage maybe until your new insurance kicks in at your new job, but you don't want to go that 3 months without coverage. So we make sure that coverage continues by maintaining COBRA coverage. Then there are retiree plans. These we do see a lot of through unions. We see a lot of the FEP, the federal employee retiree plans. Then we have supplemental plans. Think of those kind of like the AFLAC plans that just pay a supplement. Medical plans that have embedded dental benefits. Typically, these are for under the age of 18 dependents that the Affordable Care Act required that all medical insurance offer juvenile under the age of 18 dental benefits along with the medical plan. So, in order to be ACA, Affordable Care Act compliant, those medical plans have to offer that. If the employer offers a dental plan, that may not kick in, but there could be situations where you have one parent that has a dental plan through their employer and another plan that doesn't have a dental plan, but they have a medical plan with embedded dental benefits for their children. So that would be when we'd need to know about this. Then naturally we have Medicare plans, Medicare plans and Medicare Advantage. And finally, we have Medicaid plans. So why is this important? This is important because we need to understand the plan priority. We need to understand what position each insurance comes in. So when we look at this, and there is a table issued by Medicare, specifically from CMS, regarding plan priority with Medicare and Medicare Advantage plans. And I am going to be sending that table out to everyone in the follow-up email tomorrow. That follow-up email will go out tomorrow to everyone, and it will include a couple of the things that we're talking about throughout today, the secondary insurance calculator, which I'll show you at the end, as well as the recording of this session. So you will be able to refer back to this through the recording. But the commercial, employer, or individual plans will always take first priority. They will be primary over any retiree plan, over any COBRA plan, over any Medicare, including Medicare supplement and Medicare Advantage plans. There are exceptions, though, as well as Medicaid. Now, the exception that I just talked about for Medicare Advantage plans being secondary to a commercial employer plan. The exception to that is if the employer has less than 20 employees, then the Medicare Advantage plan will be the primary and the employer plan will be the secondary. That will be on the table, the chart that I send out in the follow-up email tomorrow, so everybody has it and can see it. But if you have questions, refer to that table, or as always, please don't hesitate to reach out to me, email, text message, Facebook message, whatever it may be. I'm always happy to answer them. But then naturally, as we know, we have Medicaid always as the payer of last resort. If there is any other coverage for that patient, Medicaid will always be the payer of last resort, whether that is a retiree plan, a Medicare plan, a commercial employee plan, whatever it is. If they have Medicaid, that will always be last in line. It will always be secondary or tertiary. So now that we understand the plan priority, we really have to look at the different types of coordination of benefits that are out there, because there are a lot of different types of coordination. And we'll say the unfun part is that self-funded plans can typically dictate and create even special circumstances around coordination. But the First type, traditional coordination. This is what we think of when we're dealing with secondaries. This is the way it was, 15, 20 years ago. This is the way most plans coordinated. So if a patient had 50% coverage for a crown and they had primary, secondary insurance, the primary would pay 50%, the secondary would pay 50%, and the patient got off scot-free the majority of the time, especially if you were in network. That is traditional coordination. Patients can receive up to 100% reimbursement. So, again, primary pays 50, secondary pays 50, 50 plus 50 is 100%, and the patient has absolutely no out of pocket. Then we have carve out coordination. This is when the secondary determines what it would have paid if it were the primary, and then subtracts the primary payment from that amount. So if you think about it like this, if the patient has a primary, you charge $100 for a service. The primary has 50% coverage and allows $80. So they pay $40. Now, the secondary allows $100, and they say, if we were the primary, we would have paid $50. Because the primary paid 40, we're now paying 10, which brings the patient up to $50 paid by insurance. That primary allowance, remember, was 80. The patient's going to owe that $30 difference between the $50 combined insurance payment and that $80 adjustment, or that $80 allowance. And we're going to go over these in more detail towards the end with specific examples. But I just want everybody to understand it and, hear it 2 or 3 times as we go through. The next type of plan is a maintenance of benefit plan. This is where, very similar to the first type of plan, very similar to the carve out, but this is where the secondary considers the primary payment, just like with a carve out, but then they apply any deductibles or co-insurance percentages. So to use that first example where $100 fee, $80 primary allowance, primary pays $40, secondary paid 10. In this scenario, if the secondary didn't use carve out but used maintenance of benefits, they would have said, okay, we would pay $10, but the patient has a $25 deductible. So we're going to apply that $10 towards the patient's $25 deductible. Now the total of the insurance payments is $40 because that's what you got from the primary. Secondary applied it to the deductible. And the patient now owes $40 instead of $30 because that $10 got applied to the deductible. The patient still owes that $10 towards the deductible plus their $30 co-insurance. So now the patient owes $40 and the secondary insurance paid 0 out of their own pocket. They put it towards the deductible and then the primary co-insurance. Then we have a non-duplication of benefits clause. This is how the majority of self-funded plans actually work. They use a non-duplication clause if they are the secondary that says If the primary paid the same or more than what the secondary would have paid, then no payment is made whatsoever. They will not pay a penny if the primary has already paid their full allowed fee or full allowed percentage of a fee. So, where that primary has 50% coverage, if the primary paid the 50%, then this secondary plan is going to pay zero, and the patient's going to owe the 50% based on the lowest allowed fee. So, again, we're going to go over very specific examples of these with EOBs in a few minutes, but I want everybody to understand the different types of coordination because it is very important. It's very important that when we're doing an insurance verification, we're asking the insurance company, does the plan coordinate? As a secondary, what is your coordination of benefit type? I want to ask that when I'm doing a verification on a secondary because I want to at least try to anticipate how they're going to pay. And if they tell you, well, we have a non-duplication clause, then I wouldn't include the secondary insurance in any treatment plan calculation whatsoever until the primary has hit the annual max or won't be paying for something. So if you have a service that's not a covered benefit under the primary, there is a chance that the secondary plan will make payment on it because they're not duplicating the benefit from the primary. There was no benefit from the primary, just like if a patient hits their annual maximum. Again, it is very important for people to understand self-funded insurance plans are exempt from all state laws. So if your state has a law that says an insurance company cannot dictate we charge the allowed fee for a never ever covered service, self-funded plans are exempt from that and actually can and often do dictate the fee for that allowed service. The reason this is important is, again, because they are exempt from every state law. So, very important for people to understand. But when we're talking about this, remember, current employer plans are always the primary plan for the subscriber. If the patient has two current employers, we have some patients who work part-time for a company. FedEx, for example, is a great example. They work full-time job and then they have a part-time job at FedEx or UPS or any other company that offers benefits to part-time employees. So a patient could have two plans from their current employers. If that is the scenario, typically the plan first in effect will be the primary and the newer plan will be the secondary. For some reason, some misconception got out there that the full-time job is the primary and the part-time job is the secondary. And that's just not the case. Typically, whichever plan was in effect first is the primary. So if I have a full-time job at, we'll just say Walmart, that plan goes into effect 20 years ago. 2 years ago, I got a part-time job at FedEx. That plan is my secondary. But now, today, I left Walmart. That plan was terminated, and I go to work at Target. Now, my Target plan becomes effective October 1st, but my FedEx plan from my part-time job was effective 2 years ago. So now the FedEx plan becomes my primary, and the Target plan becomes my secondary. It's purely by effective date. So, very important for people to understand. When we talk about dependents, typically dependent coverage is determined by the birthday rule. So if you have a dependent child who is covered by both mom and dad, both have insurance, typically who the dependents primary and secondary are is determined by the birthday rule. The birthday rule says whichever subscriber's birthday is earlier in the year is the primary. So dad could be 10 years older than mom, but mom's birthday is in February and dad's birthday is in August. So that means the mom's plan will be the primary for those children the majority of the time. Remember, the birthday rule is not which parent is older. It's which parent's birthday comes first in the calendar year. So February for a 35-year-old mom will be the primary over a August birthday for a 40-year-old dad. That's just the way it works. Now, a divorce decree or a custody agreement could override the birthday rule. But I will tell you, I don't get involved in custody agreements and I do not get involved in divorce decrees. That is between the parents, that is between the spouses, that is between you and your ex. It has nothing to do with me. I just came across this yesterday where there was a dispute between parents over which was the primary and which was the secondary. It's been going on for 2 years, and their three kids have been coming to this office every 6 months for the past 2 years, and no insurance has made payment because they are fighting over who's primary and who's secondary. So I tell the parents I don't get involved because now, in that client that we had this issue with yesterday, now the mom, who is the parent who brought the kids into the office and signed the office's financial agreement, now the mom is responsible for the full office fee for every one of those three kids' visits for the past 2 years, because neither insurance will process or pay because of the confusion. So I very clearly tell them in advance, this is a coordination of benefits issue. You are going to have to work it out yourself with the insurance company. If it is not worked out in the next 90 days, I will be closing the claims and I will be sending you a bill, and you will be responsible for the balance in full. I make sure they know that well in advance. So now we have to talk about those medical dental plans, those plans with embedded dental benefits. And it is possible for a child to have 4 plans. You could have a primary medical, a secondary medical, primary dental, a secondary dental. If it's through different parents, now we're getting step parents involved, and the step parents add coverage onto their plan for their step children. It can get very messy. Unfortunately, I don't know of any software that allows all 4 policies to be entered. Most of them you can do 3, but that's usually the cap. So we have to be very careful about that. And then we get stuck doing manual claims. Because the other thing to remember, and this is something I had mentioned in the very beginning, but the other thing to remember is if you are in network with all 4 of those plans, you are contractually obligated to submit to all 4 of the plans. And I hear people say all the time, well, the primary paid their full allowance. I'm not submitting to secondary. Number one, you're probably leaving money on the table. Number two, if you're in network, you don't have a choice. You have to submit those claims to in-network carriers. Part of your contract, part of the agreement. So we really get into situations here where you could potentially be doing manual claim forms, or, I will hop into Vine and I will change the insurance information in Vine and then print the claim out and mail it. That way it's taken care of. So, and I do see there's a couple questions that are popping up. I will get to them. Um, just so we can get, I'm trying to save all the questions for the end so we can get through, and I'll leave plenty of time for questions at the end. But again, it's important to remember Medicaid plans are the last insurance to pay. So you will have situations where a Medicaid patient has no out of pocket. So even if the primary EOB says the patient owes a $50 deductible or a 20% coinsurance, if they're on Medicaid and it's a covered service, they typically won't have any out of pocket. So you may run into a scenario where the primary allowance is $80. They say we're applying a $25 deductible and we're paying $55. But then the Medicaid allowance is $55. So Medicaid says we're paying nothing because the primary paid our allowance or more. And you think, well, at least I can collect that $25 deductible from the patient, but you can't. You can't collect the $25 deductible because you've collected your full Medicaid allowed fee from the primary. Medicaid paid 0 because you've already collected their fee, their allowance, and the patient owes nothing out of pocket. So we have to be very careful about coordination of benefits, especially when we're dealing with Medicaid plans. Um, I'm doing about 18,000 audits for a client, and I'm probably 600 or 700 in, or I'm sorry, 6 or 7 thousand in. And what I am finding is that they weren't coordinating benefits properly. They were collecting patient portions per the primary EOB, but the secondary was Medicaid and required those to be written off. So now patients are sitting with hundreds and thousands of dollars in credits that are true credits that have to be refunded to the patients or to whoever paid it because they didn't understand coordination of benefits and were collecting from Medicaid patients based on the primary EOB when they couldn't do that. So if you do accept Medicaid, you are an in-network Medicaid provider, please, please, please remember to make sure you are doing that coordination of benefits properly. It is so important that everybody understand that. So now again, remember those Medicare plans are secondary to commercial plans. Retirement plans are secondary to Medicare plans. So you could have a patient who has a commercial plan through Target, they have a Medicare Advantage plan, and they have a retiree plan from their union where they worked their whole life, when retired from, went to work at Target part-time, got the coordination, got the coverage through Target. So now they have a Target plan. Then they have a Medicare Advantage plan as their secondary. And then they have their union retiree plan that is their tertiary. So very, very important for everybody to understand that. So now let's talk about how we actually get paid from this, because this is my favorite part. Because remember, like I said, when a patient has multiple plans, primary, secondary, tertiary, quadriary, whatever it may be, you always submit your full fee on the claim forms. Never network fees, never balances after the primary has paid. When a patient has two or more plans, you can collect up to your full office fee. Even if you're in network with one, both, or all three plans, depending on how they pay, you can collect up to your full fee and never do an adjustment. So if I'm going to get that chance, I can be in network with an insurance company, but still collect my full office fee. I am going to do that 100% of the time. Every time I can, I'm going to. So we really want to make sure we are doing that. So, be sure you are submitting your full office fee on those claim forms. Always your full office fee. And anybody who has followed, if you're a member of the Billing Academy Facebook group, anybody who follows it knows you always submit your full fee on a claim form unless you're giving the patient a discount. And remember, a contractually obligated adjustment is not a discount. It's a contractually obligated adjustment. So even if we're in network, we always represent our full fee on that claim form unless we're giving a discount. So very important to know. When you submit the claim to the secondary, we attach the primary EOB. When we submit claims to a tertiary, we submit the primary and the secondary EOBs. I always do those as screenshots or attachments. Always. There is also CAS coding, and we're not going to get into CAS coding today, but CAS coding is also important. And a lot of insurances, especially some of the Medicaids, will reject claims if you're not doing CAS coding. It's CAS. If you want to look that up, I know Vine has a great section on their website about it. There's a lot of help out there for CAS coding, representing the primary payment and whatnot on the claim form. It's CAS coding. Look it up, CAS. But I'm going to still submit the claim to the secondary, and I'm representing my full office fee on the claim form. Box 31 for every service line will have my full office fee. I'm attaching the primary EOB so that they can see how it processed. And they can then take that information to determine, based on the coordination of benefit type, how they're going to process. But there are some plans that don't coordinate. Medicare Advantage plans typically pay as the primary, even if they're secondary. They don't coordinate benefits, they pay as though they are the primary. In those scenarios, I will submit to the secondary insurance right away because I know that Medicare Advantage plan is non-coordinating. I will submit the primary claim and the secondary claim on the same day, so I get paid by both that much quicker to improve my collections and improve my cash flow. And that's very important when you can. What I don't want you to do is to try and do that with everything and find out you're getting letters in the mail from the secondary saying, oops, you forgot something. We need the primary EOB. And now I run into a situation where processing that secondary or getting paid from the secondary is delayed because now I'm not dealing with the initial submission of a claim. Now I'm dealing with missing information and providing that missing information. So, when do you do those adjustments? Now, here is what I will tell you. I don't do any adjustments, even in network with one or both of the plans. I don't do any network adjustments until both plans have made payment or have processed the claim, even if it's a $0 payment. I do no adjustments until then. If a patient has multiple insurance plans, I don't post the primary or secondary allowed fee to the ledger. I post my full fee. Remove those fee schedules that are linked to that plan. Post your full office fee on the ledger, just for patients with multiple plans. And then any adjustment that does have to be done, I do after both plans have made payment or at least processed the claim. So now the question becomes, how do we do that? And how we do that is by stopping the automatic adjustments. So again, remember I said I remove those fee schedules from the plans. But how do you do that? Because if a patient only has one insurance, I want the fee schedule to post. I want the treatment plan and the walkout and my end of day reports to reflect the allowed fee. Because if you're in network with an insurance who allows $1,200 for a crown, but your full fee is $1,500, and you do a crown for that in-network patient, you didn't produce $1,500. You produced $1,200 because that's the amount you are going to get paid. That is the maximum you're going to get paid for that crown is $1,200. You're in network with their plan. It's a covered benefit. The most you're going to get paid is $1,200. So I don't want to see the 1,500 on my end of day report because that could inflate my end of day by 10, 15, 20, 30%, 40%, depending on how many patients you're seeing and what procedures you're doing. So how I do this, and I stole this, I will be very upfront with you. I stole this from Andre. Anybody who has Eaglesoft should know Andre's Eaglesoft field guide. I 100% stole this from him. I give him all the credit in the world because the idea came from him. So when a patient has multiple plans, I create two plans for the same group. So you have a Microsoft plan. This is for patients who only have Microsoft. It's their primary, it's their only insurance. They don't have a secondary. I put all that information into my software. The employer name, the group number, the deductible, the annual maximum, et cetera, et cetera, et cetera, et cetera, et cetera. What's covered at 100, what's covered at 80, what deductible applies, what deductible doesn't apply to. And I link the fee schedule. That way I'm getting accurate reporting on my end of day reports. However, for patients that have Microsoft and another plan, I will create that same exact Microsoft plan. If your software allows you to, copy the plan. If not, recreate an exact copy of it, except instead of naming it Microsoft, I'm going to name that plan or that employer Microsoft 2 or Microsoft, all capital SEC for secondary. And it is a copy of the plan. The allowances, the percentage of coverage, the what deductible applies to, the amount of the deductible, the annual maximum, et cetera, et cetera. Everything is identical. It's a copy of the plan, except I remove the fee schedule. So it has everything posted to the ledger at my full office fee. And why do I do that? Because I don't want it posting at the primary allowance, because that's how all softwares are designed. If a patient has primary and secondary, it will post the primary allowance. But then if the two plans pay more than that together, now I have to do a debit adjustment to offset that. It's a lot of calculation. So I end up doing debit adjustments on some line items, and I could be doing credit adjustments on other line items, and it just gets very, very messy and leads to a scenario like that client that I'm working with right now has, where you have $900,000 in credits sitting on your AR report because somebody didn't understand how coordination of benefits works. And I don't want that to happen to anybody out there. So create those two plans. So if you have a patient who works at Microsoft and their spouse works for Walmart, you're going to have, oh, they have primary and secondary. I'm going to link Microsoft 2 as their primary, and then I'm going to link Walmart 2 or Target 2 or whoever their secondary is as the secondary. That way, neither plan has the fee schedule attached. Everything walks out at the full office fee. It posts to the ledger at full office fee. And I'll do any adjustments after both plans have processed. Very important. So I'm going to answer a couple questions here. And if I'm ignoring or skipping over your question, it's because I'm going to address it coming up here. So the first question, we'll get this one out of the way. How do we obtain our state laws so we can understand and know those? There are so many. It's something you just have to know. We have on the resources page of our website, we have most of the requirements, the laws, the rules broken down So if you want to know what's the state law on can a patient have a discount plan and insurance? We have that on our resources page. If you want to know what your state law is for never ever covered services, we have that on our resources page. So I will send you a link to that resources page in the follow-up email tomorrow. But if you want to get there sooner, just go to practicemechanic.com, click on resources in the upper right-hand corner, and it will take you right to it. What I will tell you is be very careful asking or trusting Google or Chat GPT or any of those. They're great for some things, but I see a lot of incorrect information on there. Um, just yesterday, somebody posted in the group about an office that was charging 24% interest on past due balances, but that practice was in Arizona. And when you look it up on Google, it says 24% is fine and legal. But that's if you're a lending institution, a subprime lending institution. It's not for medical providers. So it was right, but it wasn't right specifically for us. So be very careful about trusting those things online. Do your research, go to your state website, or quite honestly, reach out to your state dental association or the state dental board, and they will be happy to answer that. So now somebody asked, how are we supposed to put in a third insurance? I'm seeing there's only a place for primary and secondary dental. Joyce, that's going to depend on your software. Some you can and some you can't. EagleSoft, there's a place to put a supplemental insurance. And you can enter that in there. Dentrix allows for it. I know Open Dental will allow for it, but I don't know every software out there, so it's going to depend. If you can't figure it out, I would suggest calling the support line and ask them, how do you put a tertiary in? But again, not all insurances do allow it. So you may end up, when you have a tertiary, you may end up having to do that claim for it manually. Um, so someone asked, how can a dental office be in network with medical insurance? Well, first of all, it is possible. I've seen a lot of dental offices that are starting to do TMJ treatment or doing frenectomies who are in network with a medical insurance plan, and it is allowed. But most of the time, if you're talking about the medical plans that have a dental rider, most of the time, those medical plans will sub that out to their dental division. So if you have medical insurance through Blue Cross Blue Shield and it has a rider for juvenile coverage for dental, it'll be Blue Cross Blue Shield dental that will actually process and pay it. So while it is possible, it's not normal. It does happen. Um, so that's the way it works. Joanne, I'm gonna skip yours just because we're gonna get to it here in some examples. So please don't be mad that I'm skipping it. Um, Someone else asked, is there a situation when the insurance holder is responsible for the balance, I'm assuming, rather than the parent who brings the child? Not in my office, no. Whoever signed the financial agreement is the one who's responsible for the balance. If they have a court order that says parent B must pay for insurance and cover any co-insurances, deductibles, etc., then they are responsible. But it's parent A's job to get reimbursed by them unless they call in advance and pay with a credit card over the phone. I'm not going to see a patient without that being paid. And whichever parent signed my financial agreement is the only parent I can legally send a bill to. That parent B didn't sign my financial consent. So just because they have insurance doesn't make them the responsible party. My son, I mean, unfortunately, he just got DiCaprio'd because he just turned 26. But last year, he was on my health insurance. I was not his responsible party. I'm the subscriber for the insurance, but I was not his responsible party. He had to pay his own co-insurances, co-pays, and deductibles. Just because I was the subscriber doesn't make me his responsible party. He's an adult, he's his own responsible party. In these other scenarios, the parent or the person who signs the financial agreement and agrees to be financially responsible is financially responsible. That's the way it works. So, another question here, what about coordination of benefits when there is step parents involved? I've been told who the child lives with can also affect coordination of benefits. It is true. Um, the children's primary residence could affect that. So it just depends on the plan and how it's written and what their coordination of benefits clause is. But it is possible that, let's say, a child lives with mom and stepdad, but dad also has coverage. So mom has coverage, stepdad has coverage, and dad has coverage. Mom and stepdad's coverage could be primary and secondary, which pushes dad's coverage to tertiary if the coordination is based on primary residence or physical custody. It's rare, it happens. Honestly, I probably see it maybe 10 or 15 times a year over hundreds of thousands of claims. But it is possible. And if it's the insurance company telling you that, then they probably know how that plan coordinates and they are doing that. Um, we're good there. Next question, then we're going to move on to examples so we can get through, and I have plenty more time. What is the best way to determine if an employer has less than 20 employees? How does your office handle it when you ask the insurance company if the plan is self-funded and the rep has no idea what you're asking? Two different questions. The best way to determine if an employer has less than 20 employees, really the simplest way is ask the patient. They'll know. A lot of the time you're going to know. I mean, listen, if it's they walk in with a General Electric plan, we know GE has more than 20 employees, or Walmart, or Target, or any of those. If it's a company you're not familiar with, sometimes just a quick Google search of the company will tell you. But you can always ask the patient, the subscriber, or I'll call the company and ask to speak with someone in human resources. If they say we don't have a human resources person, there's a good chance they have less than 20 employees. But I would then say, okay, I need to talk to whoever does your benefit administration. I'm calling from one of your employees' doctor's offices, and I just need a real quick answer to a question regarding your insurance. I'm not afraid to do that. I'm not afraid to reach out and talk to whoever I need to reach out to. If you have an HR person, that HR person is typically going to be schooled in benefit negotiation, and they're going to understand why you're asking that question. But again, you can always ask the patient or the subscriber, and they should know. Now, the second part to that question was how does your office handle it when the insurance company doesn't know, when the rep doesn't know if a plan is self-funded or fully funded? Unfortunately, you can't always get that answer. A lot of insurance companies have started putting it on the EOB. Aetna, some of the deltas, they put it right on the EOB now. So you can always look back at an old EOB if you have one for that patient or for that plan and see if it's on there. Like I said, I know Aetna is great about it. Cigna has started putting it on some of them, depending on which layout you get. So, important for everybody to know, but I still run across reps who say, "Well, what do you mean self-funded?" No, no, this is an employer plan. Yeah, I know, but only employer plans can be self-funded. And the reps just don't know. So, you can always ask for a supervisor, but there are also some deltas. I think there's still 3 or 4 delta companies out there of the 38 deltas. There are still 3 or 4 that if you ask them if the plan is self-funded, they will tell you, "We're sorry, that's proprietary information and we can't tell you." Now you just have to wait and find out how the EOB process is in order to make that determination. So, very, very important for people to understand. So now let's go and look at some actual examples here. So in this example, you see this primary, which is MetLife. The patient had a limited oral exam. The office is in network. We see that with the negotiated fee. The office is in network with a negotiated fee of $56. MetLife applied $50 to the deductible and then paid their remaining percentage, because here it's only covered at 80%, paid their remaining percentage on that $6 of $4.80. So MetLife paid $4.80 with a patient portion of $51.20. The second Delta EOB notes that the other carrier is MetLife, and they based their allowance, the maximum approved fee, on the primary's allowed fee. So for this client, I just happen to know their delta rate for a limited exam for a DO 140 is $61. But Delta is using the primary's allowance to pay, and as you see, they paid that lower allowed amount of $56. So now we go to the secondary insurance calculator. And if you haven't downloaded this yet, it's an Excel spreadsheet. It's in the group files on the Billing Academy Facebook group. But I will also be sending you a link to it to download in the follow-up email tomorrow. So we see here on that secondary calculator, we put in the code, the office's full fee. Do not, when you're using this calculator, put in the fee you posted to the ledger if you accidentally posted the primary allowance. Don't do that. Put your full office fee there. I don't care what's posted to the ledger. It should be the full fee, but that doesn't affect our calculations here. The office's UCR does. So we put in the office UCR of 114, that primary allowance of 56, primary payment of $4.80, secondary allowance of 56, because remember, Delta matched the primary, and then they paid 56. So I have now collected $60.80 from the 2 plan payments. But instead of adjusting from 114 down to 56 and doing a $58 adjustment, because it would have been a $58 adjustment because the two insurance payments paid $60.80 together. I'm only doing a $53.20 adjustment. I'm making an extra $4.80 because this patient had a secondary. If they had only had that MetLife primary, I would have only made $56. But because they have that secondary, I'm making $60.80, that extra $4.80. So it lowers my adjustment. Sometimes it can eliminate it. And I'm only doing a $53.20 adjustment. Now, if you had prematurely written off down to that $56 primary allowance and you didn't catch it, this patient would now have a $4.80 credit on their ledger, because we're adjusting to 53.20 instead of 58. If you had prematurely adjusted a $58 adjustment, gone down to 56, this patient would have a credit on their account. And then they're going to look at that and they're going to go, I want my $4.80, because you missed doing the debit adjustment. And that happens. Nobody is perfect. I don't expect anybody to catch it 100% of the time. But in this scenario, it would have cost us money. So now let's look at the next set of EOBs. This is another PPO, another Delta PPO product for a periapical x-ray, a buildup, and a crown. So we see the submitted fees. These are the full office fees, $22, $240, $996. Here is our maximum approved fee. This is another office that's in network. So we're doing a $3 adjustment, a $48 adjustment, and a $264 adjustment. Insurance paid based on their 50%. They applied the deductible there, and insurance made these payments, leaving a patient balance of $0 for the PA, $121 because of the $50 deductible for the buildup, and $366, excuse me, as their 50% coinsurance for the crown. However, the secondary paid nothing towards the PA. Fine, it was paid in full here. They paid nothing for the buildup. Nothing at all. Because they did that adjustment there. So now we have to look. And we have to say, okay. And remember, it is very important that when you're doing this, you do it by line item, not by total. It's very, very important. So now we have the primary allowed 19, paid 19. Secondary allowance was 19 and paid 0. $19 total insurance payment for that PA, and my $95 adjustment, because my fee is $114. Was that $114? Somebody messed that slide up. It was $22. So really it's a $3 adjustment. Somebody messed up that slide. Don't pay attention to that line. Now we go down to the buildup, but it should be a $3 adjustment. But that's why we do line item. That's why we do line item, because you could skip something. I see what happened. Somebody was recreating it and forgot to change that 114 UCR from the limited to the 22 for the PA. And by somebody, I mean that was probably me. So ignore that PA line there. But the $29.50, the buildup, $240 full office fee. Primary allows $192. Secondary allows $192. Primary paid 71, secondary paid nothing. The patient's portion is 121, and my adjustment is going to be 48 to take us from 240 down to the 192. Secondary used the primary allowed fees again because they're lower than the secondary's allowed fees. DO 220 was paid in full by the primary. Patient owes zero. The build-ups based on the primary allowance and co-insurance, patient owes 121. For the Crown, the secondary paid 50% per the primary EOB. They paid 366. The primary paid 366. I've collected 732, which is the allowance. The patient owes $0. So the patient's entire out-of-pocket for this PA, build-up, and Crown is $121 that's getting applied towards the build-up. Next example. And again, please remember if you're having a tough time reading these, sometimes you might be on a phone or on a small screen or a tablet. I'm going to email you a PDF of this presentation so you'll be able to zoom in and look at this and see everything if you need to review this at all. So now we have a periodic, we have 4 bite wings, and we have a prophy. Standard recall. Exam, bite wings, prophy. Standard recall. We see here insurance paid, the primary paid 169, which is 100% of their allowance. Here we see that secondary also paid 100% of their plan, but they did an adjustment and ended up paying $0 because we see Cigna coordinated benefits and said the primary paid equal to or more than we would have if we were primary. We're paying nothing. They did a maintenance of benefits adjustment, took 143 out of what they would have paid and paid you 0. So we still see here now everything being based off of the primary allowance. Patient owes nothing. The total insurance payments are here. I've collected 39, 53, and 77. I do the adjustments to bring it down from our full UCR to the primary allowance. Patient owes $0, as you can see. So now let's get into a fun one here. And I'm actually going to skip this because I want to get to one of these fun ones. So here we see this is another prophy and exam. Prophy and exam. Here, the office is out of network with the primary. So because the office is out of network with the primary, the patient is responsible for the difference between the primary's allowed fees and the office's full office fee. There is no adjustment due there. But the office is in network with the secondary. So when we look at this, and you see right here, total benefit paid is 43 cents. So how did that happen? The office UCR is $75. The primary allowance, because we're out of network, the primary allowance is $75. The primary paid $53.88, but the secondary allowance is 47. So the primary paid more than the secondary allows. Here we see for the exam, Our office UCR is 53. Again, the primary allowance is 53 that matches our UCR because we're out of network. However, the secondary allowance is $35. So now the secondary in this case, that's what they paid that 43 cents towards. They paid the 43 cents towards that exam, which means the patient owes the difference between the total of the two insurance payments, which was $28.12 for the exam, and $6.88 is the patient portion, because the patient owes the difference between the two insurance payments and the lowest allowed fee. In this scenario, the lowest allowed fee is the $35 secondary allowance. But up here, you see, I'm not writing off from $75 down to $47 for that pro fee. I'm only writing off $21. I'm writing off the difference from 75 down to 53.88 because that's the total of the two insurance payments. So I'm actually, again, I'm able to collect more than the lowest allowance here, that in-network allowance with Cigna. I'm allowed to collect more because the primary paid more. So I make more money. In this scenario, I make an extra $6.88. I'm making an extra 15% on that pro fee because of the primary payment. And I write off only down to the $21.12, not down to the 47, but right off to 53.88, which is the sum of the two insurance payments. So I'm making more money. The patient is spending less money because, remember, if they didn't have that secondary, they would have owed me $21.12 for the pro fee and $25.31 for the exam. But here, the patient only owes $6.88. So it's a great, great thing. Now, let's look at one that's even more fun, because now we're dealing with Medicare, who's not going to do any coordination of benefits. And we see this patient had a number of fillings, 2 pulp caps, and a buildup. So we see all of those here. But in an effort to be able to read it better, let's look at the secondary calculator. So here we see for the fillings, the full office fee, UCR, is 260.76. We're out of network with the primary. So the primary allowance matches our UCR in the calculator because we're out of network. 260.76. And please, 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 for anybody listening out there, do me a favor and please make your prices even dollar amounts. I understand people that say we're going to raise our rates by 5%, and they go in their software and they do a 5% increase. Round it off to the closest dollar. Nobody wants to be doing these calculations. What's 0.8% or 0.75% of $260.76? Make it round numbers, please. But with that said, the primary allowance, they're paying based off the full office fee, $260.76. They paid $208.61. But now remember, the secondary is a dental Medicare Advantage plan. Medicare Advantage plans don't coordinate benefits. So they paid as though they were the primary. So you see here, we're out of network with the primary. They paid $208.61. that would have left the patient a portion. However, the secondary we are in network with, and they allow $157. And they paid $157. So now we have a scenario where my office UCR is $260.76, but I've collected $365.61 from the insurance payments. So you see how this says negative 104.85 is my adjustment off of UCR? It says that because this is a patient credit. Now, in some scenarios, that credit would have to go back to the secondary. You would have to call the secondary, you would have to have them reprocess, taking coordination of benefits into account, and they will do a refund request for that $104.85 per filling. However, because this plan is a non-coordinating Medicare Advantage plan, everybody get ready. That $104.85 times 4, so $416 plus a little bit, goes to the patient. You see here, patient portion 000000000. The patient owes nothing out of pocket, but you're actually going to write them a check for $416 because their secondary is a non-coordinating, and you can only collect your office UCR. You can't collect more than you charge. Because the secondary is a non-coordinating Medicare plan, that $416 credit, 104 times 4, you write the patient a check for that. So yes, there are scenarios where the patient can profit by going to the dentist. It's possible. Now, this is again why I say do everything by line item. You do have to do an adjustment for the 2 pulp caps and the crown buildup. But still, I've collected more or equal to. For the 2 pulp caps, I collected the allowed fee. The secondary allows 65, I collected 65. However, for the buildup, they paid $17.56. They paid $174. The allowance is $174. I've lowered my adjustment and collected an extra $17.56. Not huge money. But here's my question for you. Because remember, this 104.85 times 4, I keep saying 116, but it's actually not 116. It's actually, or 416, but it's actually 419.40. You are going to write a check to this patient who paid $0 out of pocket. You're going to write them a check for $419.40. And here's my question for you. And, Yoon, I hope this just answered your question, because your question was, if they don't coordinate, can they pay over our office fee? They definitely can. Here's the scenario where they did. The patient gets a check. And how easy is it for you to get patients to agree to treatment when they're getting paid by their secondary to get that treatment? This patient spent $0 out of their pocket, came in, got 4 fillings, 2 pulp caps, and a buildup, and walked away with a profit of $419.40. If I was this patient, I would be saying to you, what 4 fillings are you doing tomorrow? And then what 4 fillings are you doing the day after that? And how many teeth do I have? And how many times can you do these fillings? Because I'm getting paid $419 every time you do a filling. I'll come in every day, keep redoing them. I mean, we're going to hit max in frequency, and no dentist is going to do that on a tooth that doesn't need it. But how easy is it to get patients to accept treatment when they're getting paid to accept the treatment? So very, very important. It helps us close more treatment, collect more money, and make patients happier by properly coordinating benefits. So I really hope everybody understands that. I'm going to get to questions now. We have a couple here. We'll wrap up. Again, I am going to send you over the entire presentation as a PDF. I'm going to send you the recording of this video and links to the secondary insurance calculator and our resources page on our website. So now, first question, Joanne. Office is out of network with patient's primary. It pays on a specific fee schedule. Procedures billed out as $200, primary paid $55.50. EOB states patient owes $0 because they pay 100%. Secondary paid nothing despite contract fee being $150. Says that is because we were paid by primary. Secondary states patient's not responsible. How is that right? That doesn't seem right to me. If you're out of network with the primary, they can't dictate that. So unless there's some clause, or unless you're in network through an umbrella you're not aware of, or something weird like that, that doesn't seem right. The maintenance of benefits, the coordination that the secondary did, saying no, primary paid, we're not paying anything, that is right. But it's not right that an out of network insurance will tell you that, unless, and here's the big unless, if that office you're out of that insurance you're out of network with, that patient's primary, Joanne, is Blue Cross Blue Shield of Michigan, and you accept assignment of benefits, you do have to write off down to what they pay. So that's the only scenario where they can do that. Blue Cross Blue Shield of Michigan can dictate an allowed fee and demand a write-off if an out-of-network provider accepts assignment of benefits. So that would be the only scenario where that could happen, and I would be willing to bet that's what it was. So next question. What is the requirement when a dental plan requires we bill medical for a procedure, usually with IV sedation and wisdom teeth extractions? You can tell I've been working on a lot of outlines lately because I almost read IV as 4. But if you're in network with the dental plan, you absolutely submit to the medical. I submit the dental claim form to the medical. Usually it will come back with a denial. I then send that denial from the medical to the dental, and they will pay for it. Although sometimes, Kimberly, you will get a payment from the medical. It's rare. I just want the denial so I can send it over to the dental. Next question. We were told by insurance companies that we cannot go line by line, only total cost of primary and secondary right off to the lowest allowed amount. They are wrong. If you read the coordination of benefits rules, and these are all set by the NAIC, the National Association of Insurance Commissioners. These rules are set by them at their NAIC conference every year, and then they go back to their individual states and put those rules into place. They're the ones that set those rules, not the insurance companies. So they're wrong. They're trying to do what benefits the patient the most, and I understand that. Unfortunately, they're wrong. So, next question, Connie. Even though between the two, they paid our in-network fee for the secondary and the EOB says patient owes zero, we can collect based on line item. I have a lot of secondary insurance to take the total claim amount into consideration. I go by line item. So you absolutely, the patient could end up with a balance for the exam, but a lower adjustment for the pro fee. 100% that is possible. Now, Yoon, for that case where primary was out of network and secondary was in network, do we collect 688 from the patient? You put pay. I know somebody messed up the slides. In that scenario, yes, I would collect the $6.88 from the patient, and I will fix the slide before I make it a PDF and send it out to you guys. Do these rules apply to oral surgeon's office? These are federal coordination of benefits rules. So they apply to oral surgeons, they apply to endodontists, they also apply to physicians, primary care physicians, emergency room physicians, so on and so forth. It is the same across the board for every physician in the US. If you're in network with primary and out with secondary, do we honor the primary contracted rate? As you saw on the calculator, any patient portion is based on the lowest allowed fee. In this scenario, it would be the primary. But between the two plans, you can collect up to your full office fee. But if the patient has any out of pocket, that out of pocket is based on the lowest in network allowed fee. Whether it's the primary or the secondary, whichever is the lowest, that's what the patient owes. Katie, if a kid had Blue Cross Blue Shield embedded pediatric medical plan and Delta Dental, what is primary? We're told Blue Cross Blue Shield does not coordinate, and Delta always pays as primary. A lot of the embedded medicals don't coordinate with dental. So, honestly, I would bill them both. Bill them both at the same time. If either are going to coordinate, you'll get a letter back saying we need the primary EOB, and then you'll know. All right, next question. If there's no coordination of benefits, does the patient get the overpayment? Yes, they do. If the plan is non-coordinating or self-funded. And that's where the self-funded thing comes into play. If that patient has a primary or secondary that is a self-funded employer plan, they get any amount paid over your full office fee. I know, Connie, question regarding the example where the calculator says patient owes 688. I know I messed it up. I'm sorry. And yes, Katie, the patient gets the overpayment in that scenario because it's non-coordinating. And the last question, does secondary insurance usually know the patient does have a secondary? 99% of the time they know. There are national databases where they know that. And that's why we get those letters in the mail saying, why is this? Why is that? But they do know 99% of the time. Very rarely they won't, but that's why if it is a coordinating plan that doesn't coordinate, I will call them and let them know. Um, who should notify the insurance companies if the patient has primary and secondary, but the insurance aren't aware of the other plan? When you submit the claim form has a spot where you put other coverage. You have to put that on there. So you're notifying them by submitting the claim. If they ignore that, that is 100% on them. I still will call if they process incorrectly and let them know, but that is 100% falls to them. That's the way it is. I will let them know that. That is it. I hope everybody learned a lot. We'll send that email out tomorrow. So it'll have a replay link to this video. It will have the secondary calculator. It will have the presentation with the corrections as a PDF, a lot of other information, and my contact info. So if you do have questions, if you do need any help, please, please, please don't hesitate to reach out. But that is it. Everybody, thank you so much for being here. Let me know any questions you may have. I appreciate it. Have a great rest of your week. And for you guys in the group, I will see you tomorrow morning for the Drive Live video Friday morning. Thank you so much.